Welcome to today's video, where we'll be diving into a potentially serious condition affecting the digestive system, gastric varices. We'll explore what they are, what causes them, how they're diagnosed, and the available treatment options. So, let's get started. Gastric varices are essentially enlarged veins in the lining of your stomach. But what leads to this abnormal growth? The primary culprit behind gastric varices is portal hypertension. Portal hypertension is a high blood pressure in the portal vein, which carries blood from the digestive organs to the liver. This high pressure causes blood to back up, searching for alternative routes to return to the heart. These alternative routes often involve veins in the stomach and esophagus, leading to their enlargement and the formation of varices. Cirrhosis, often resulting from chronic liver disease like hepatitis or excessive alcohol consumption, is the most common cause of portal hypertension. Less common causes include splenic vein thrombosis, Budd-Chiari syndrome, and portal vein thrombosis. Now, let's understand the mechanics behind gastric varices. Portal hypertension, as we mentioned, is the key. This elevated pressure forces blood through smaller, more fragile veins in the stomach wall. These veins become dilated and tortuous over time, essentially bulging outwards, forming varices. Because these veins are thin, walled, and under significant pressure, they are prone to rupture. When a gastric varix ruptures, it can lead to a potentially life-threatening upper gastrointestinal bleed. The severity of the bleeding depends on the size and number of varices, as well as the overall health of the patient. Gastric varices are most frequently observed in individuals with pre-existing liver disease. This means their occurrence closely mirrors the epidemiology of liver cirrhosis and other causes of portal hypertension. Studies suggest that a significant proportion of patients with cirrhosis will develop varices, either esophageal or gastric, during the course of their disease. The prevalence of gastric varices, specifically, is lower than that of esophageal varices, but they tend to be more prone to bleeding. Factors like alcohol abuse, chronic hepatitis B or C infection, and non-alcoholic fatty liver disease can significantly increase the risk of developing cirrhosis and subsequently, gastric varices. The presence of gastric varices themselves often doesn't cause any symptoms. However, the most concerning symptom arises when they rupture and bleed. Bleeding from gastric varices can manifest in several ways. Hematemesis, which is vomiting blood, is a common sign. The vomited blood may appear bright red or have a dark, coffee ground-like appearance. Melena, or black tarry stools, indicates that blood has been digested in the gastrointestinal tract. In severe cases, significant blood loss can lead to symptoms of anemia such as fatigue, weakness, and shortness of breath. If the bleeding is massive, it can cause hypovolemic shock, characterized by a rapid heart rate, low blood pressure, and altered mental status requiring immediate medical intervention. Diagnosing gastric varices typically involves a combination of clinical evaluation and imaging techniques. An upper endoscopy, also known as esophagogastroduodenoscopy or EGD, is the gold standard for diagnosis. This procedure involves inserting a thin, flexible tube with a camera into the esophagus and stomach, allowing direct visualization of the varices. Endoscopy can also be used to assess the severity of the varices and any signs of recent bleeding. Additionally, imaging studies like CT scans or MRI scans can help evaluate the liver and portal vein for evidence of cirrhosis or portal hypertension, further supporting the diagnosis. Liver function tests are also typically performed to assess the extent of liver damage. Gastric varices can be classified based on their location and association with esophageal varices. According to the Sarin classification, GOV1 varices extend from the esophagus into the stomach. GOV2 varices extend beyond the cardia, which is the junction between the esophagus and the stomach. IGV1 varices are isolated gastric varices found in the fundus, and IGV2 varices are isolated gastric varices found elsewhere in the stomach. This classification system helps guide treatment decisions. The management of gastric varices focuses on preventing and treating bleeding episodes. Treatment strategies include medication and endoscopic interventions. Beta blockers, such as propranolol and nadolol, are often prescribed to reduce portal pressure and decrease the risk of bleeding. In acute bleeding situations, endoscopic techniques such as band ligation, where small rubber bands are placed around the varices to cut off their blood supply, or sclerotherapy, which involves injecting a substance into the varices to cause them to shrink and scar, are commonly used to stop the bleeding. In some cases, a procedure called TEPS, or transjugular intrahepatic portal systemic shunt, may be necessary. TEPS involves creating a channel between the portal vein and a hepatic vein to reduce portal pressure. Balloon-occluded retrograde transvenous obliteration, BRO, is another interventional radiology technique specifically for gastric varices. Liver transplantation may be considered in patients with severe liver disease and recurrent variceal bleeding. While it's not always possible to completely prevent gastric varices, particularly in individuals with advanced liver disease, there are steps that can be taken to reduce the risk. The most important step is to manage and prevent liver disease. This includes avoiding excessive alcohol consumption, getting vaccinated against hepatitis B, and seeking treatment for hepatitis C. Maintaining a healthy weight and managing conditions like diabetes and high cholesterol can also help prevent non-alcoholic fatty liver disease, a major contributor to cirrhosis. For individuals who already have cirrhosis, regular monitoring with endoscopy can help detect varices early, allowing for timely intervention. The prognosis for individuals with gastric varices varies depending on the severity of the underlying liver disease and the effectiveness of treatment. Untreated bleeding from gastric varices can be life-threatening. With proper management, however, the risk of bleeding can be significantly reduced. Recent research has focused on improving endoscopic techniques for treating varices, as well as developing new medications to reduce portal pressure. Studies are also underway to investigate the potential of regenerative medicine approaches for repairing liver damage and preventing the development of portal hypertension. One promising area of research is the use of drug-eluting beads during transarterial chemoembolization to target gastric varices, potentially reducing the need for more invasive procedures. Continued research in this area is essential for improving the outcomes for patients with gastric varices.